Good afternoon, Chair, ladies and gentlemen. Thank you for the opportunity to present our work from Birmingham. Thoracic injury sustained in combat is associated with significant incidence of mortality and morbidity. Mortality was reported to be as high as 27% back in the World War I, and subsequently in Vietnam and Bosnia was reported at 3%. In the recent conflicts in Iraq and Afghanistan, the improvised explosive devices have become the main mechanism of injury. Casualties made by these devices present with multiple injuries, contaminated wounds, and significant blood loss. In a previous UK registry study of thoracic injuries sustained from these two conflicts showed that 10.5% of all admitted military trauma patients had thoracic injury. And the thoracic injury-related mortality in that series was 14.3, and the data included the local civilians. So when a military personnel becomes injured, they receive body aid at the point of wounding under the principles of battlefield advanced trauma life support. They are then transferred via the medical emergency response team to a Row 3 field hospital where they undergo damage control surgery and damage control resuscitation. And then finally onto Row 4 for definitive care with a specialist. For the benefits of our audience, a Row 3 field hospital has surgical capability, intensive care, blood bank, laboratory, and a CT scanner. The deployed UK surgeons are from the background of general surgery, plastics, and orthopedics. A Row 4 is defined as a fixed capability of a host nation which has the full capabilities of the NHS. So, as we previously had looked at the early outcomes of these thoracic injuries managed at Row 3 in a facility where there's no continuous cardiothoracic specialty input, it is unclear that the level of cardiothoracic requirement for these patients on return to the UK. Hence, the study is to evaluate, number one, the outcome of British casualties repatriated to Row 4, looking at the injury pattern, mortality, and morbidity. And number two, to examine the impact of specialist cardiothoracic involvement in these patients. So the study was approved by the RCDM, and the casualties were identified using the UK Joint Theatre Trauma Registry between March 2006 and 2011. The hospital numbers were acquired, and they were cross-referenced to the data from the cardiothoracic department at the University Hospital Birmingham referral records. We are also particularly interested in patients who had thoracotomy and were also coded to have pulmonary contusions. Hence, for that group, we have looked into the case notes and explored data on the chest drain management, further procedure post the thoracotomy, and the level of cardiothoracic involvement required. So this slide shows that 182 patients were identified to have sustained thoracic injuries and were admitted to Row 4 from the JTTR data in this 5 years. So table 1, you can see that our casualties are young, median age of 24, they're all males, and the injury severity score was 18.5, so more than 15 indicates major trauma. And the mechanism of injury is mainly improvised explosive devices. Table 2 showed us that most of our casualties have associated injuries. The abbreviated injury score of 3 indicates serious injury, and AIS 6 would have been defined as an unsurvivable injury. So you can see that a lot of patients with a serious thoracic injury onwards will have other areas that are severely injured. Looking at the 64 patients that were coded to have pulmonary contusions or had a thoracotomy, 87.5% of them were admitted to ITU at Row 4, and 9.4% were requiring readmission to ITU. The median ITU stay was 8.5 days, and the median ward stays was 12 days. And in that group, there was one casualty that unfortunately died. 70% of patients had pulmonary contusions, and 43% of them developed chest infections. One patient required ECMO support. This next slide, table 3, shows the indication of the Row 3 thoracic surgery and the surgical approach required. there were 14 patients that had thoracotomies prior to arrival in the UK row 4. And of these patients, 3 of them had to undergo further surgery. One had a bilateral thoracotomy to retrieve a swab that is known to be retained in row 3. And there was one with a left thoracotomy for a left carotid to subclavian vein graft, and one redo median sternotomy to locate a shrapnel and evacuate a pericardial effusion. And the next table 4 shows the surgical interventions carried out at row 4. We then look at the chest drains management. 42 casualties had chest drains inserted on the day of injury, either at the pre-hospital row or the row on the field hospital. 30% of them required reinsertion, and 11 of them was done in row 4, of which 7 were done by cardiothoracic surgeons. There were 6 patients that required complete new chest drains insertion for pneumothorax and hemothorax. And the cardiothoracic team were involved in the daily review and management of chest drains along with the intensive care colleagues. So looking specifically in the level of cardiothoracic specialist input, 24 patients were referred to cardiothoracic surgery, of which more than 70% were seen on the day of admission, and 38% was reviewed by the cardiothoracic consultants initially. And of the 24 patients, 11 of them required surgical intervention, and 19 patients were eventually followed up by the cardiothoracic team. And 1 patient required extensive input from the cardiothoracic team in the ECMO support. So in conclusion, this is the first study to evaluate the specialist cardiothoracic input in the management of UK casualties with thoracic injuries. Often patients have severe injuries and complicated injuries, and it's prudent not to overlook the thoracic injuries. A multidisciplinary specialist approach is required to manage these complex patients to optimize management. There are, however, limitations to the study. It is an innate retrospective review with its problems, and with the JTTR, there's often undercoding, so there might be some patients that we have missed. In terms of future work, we are not clear at the long-term functional outcome of the military patients with thoracic injuries. Therefore, a study has been approved to look into this. We've also appointed a military respiratory specialist to be involved in the care of these patients. We will encourage robust prospective data collection to give further insight of the long-term outcomes of these patients. So, as part of the quality performance indicators with this multidisciplinary approach to our management of trauma in our military patients, perhaps this could be translated to the civilian practice. Thank you.